So we start today the conversation about the respiratory system. You will see that it goes in conjunction with cardiovascular system at all. Basically, what I don't talk about the oxygen transport in cardiovascular because I prefer to talk about the transport of oxygen by the blood in the respiratory. So it's really hard to separate them structurally because they are so connected. So the whole function of respiratory system is to deliver oxygen to the tissues and get carbon dioxide out of them. The entire, all the functions, all physiology of respiratory system is guided by these two objectives. And you can separate respiratory system into two major zones. The conducting zone, responsible for gas transport, consists of organs such as nose, pharynx, larynx, trachea, well, a bunch of bronchi, which you can't really see in this image. You can consider lungs being a part of conducting system as well. And then you have a respiratory zone. In respiratory zone, the actual exchange between the blood and the air occurs. Does that make sense? So respiratory zone would include those grape-like structures known as alveoli. That's where exchange happens. Okay? We're clear. There are four processes that occur during respiration. First process is pulmonary ventilation, delivery of gas into the lungs. Okay? Delivering of air into the lungs. Or exhaling it out. Then there's a step called external respiration. So that's an exchange of oxygen and CO2 between the blood and the air in the alveoli. Then there's a small and, rather, well, sort of not kind of important component of transport. So oxygen gets delivered to tissues and CO2 gets delivered from tissues back to the alveoli. And there's a component called internal respiration, which is the gas exchange between the tissues and the blood. The moment where oxygen actually gets to the tissues and CO2 moves from tissues to the blood. Any questions about this? The basic structure. So we're going to talk about the anatomy of respiratory system in the first place, and I'm absolutely positive that you're familiar with a lot of terms. I'm also positive that you might not know the names of certain structures. Turns out your nose is a pretty complicated structure. It has a root and a bridge right here between your eyebrows. And then that part, it gets broken. It's called dorsum nasi. It is formed by the nasal bone and a septal cartilage. Okay. Nostrils, the openings in your nose, and we're not considering mouth part of respiratory system because technically speaking, we're not supposed to breathe through it. We're supposed to breathe through the nose, but for someone with practically chronic allergies, it's really hard to breathe only through the nose. Okay? Then the dorsum nasi culminates with apex of the nose. Right? Nostrils or nari are bounded. I don't know, what's the normal word for these parts of the nose? Any normal word? In Russian, like literal translation, we call them wings. Wings of the nose. So the anatomical term is ala. Okay, there's a cartilaginous structures, but the point where ala merge with the face, that's just the connective tissue right here. Okay, that makes sense. That's pretty straightforward. And we're going to talk about the function of the nose much more as we move on, you know, which role it plays in the respiration. So if you imagine that you're flying a tiny little plane and you just flew into somebody's nose through the nostrils, you end up in the nasal cavity. Okay, so that's the nasal cavity. It is bound on top here by the ethmoid and sphenoid bones, and that's where the olfactory epithelium is. That's where the structures responsible for the sense of smell are. Okay. The floor of the nasal cavity is formed by the palatine and maxillary bones that form hard palati, the bony structure. So that's the hard palati. And the soft palati here with protruding uvula is the muscular structure. Okay. So in terms of mucosal lining, it's epithelial lining, as any mucosal surface has an epithelial lining. And pseudostratified ciliated columnar epithelium. So it's actually one layer of cells, but due to, you know, they appear like there are multiple layers. Cilia are necessary to move the mucus, propel the mucus in the nose, and mucus in the nose is responsible for trapping the dust, trapping the pathogens. Okay? In somebody's nose, in the nares, you're going to see a lot of hair. Tiny, fine hair. It's a really important part. We call them vibrissae, like, you know, vibrissae in cats. This hair also trap the dust particles, and they basically clear up the air that gets inhaled by the nose. That makes sense. Also, a lot of nerve endings are in the nasal cavity. Something considerably large enters it, you hopefully will sneeze it out. Doesn't always happen. Those of you who went through the stage with having little kids know that sometimes they can stick a pretty remarkable object up in the nose for no obvious reason. That's basically the only thing that always puzzles me. I understand how kids get something swallowed. That's fine. I understand that. But I still marvel about the reason why things get stuck in the nose. It's not logical. So, if you would look inside the nasal cavity, that's the actual cadaver picture. You can see nasal conchae, okay? Superior, middle, and inferior nasal conchae. Superior nasal conchae is, so they all parts of the bones. Inferior is separate bone, and superior and middle are the parts of maxillary, as far as I remember. You can see them here too. So nasal conchae, nasal conchae, nasal conchae. It basically folds, and if you see folds, you can immediately say, what's the purpose of those folds? When something is folded, surface area, yes, increased surface area. So those gaps between the, they're like flaps, okay? And those grooves between the conchae the flaps, basically, between the flaps. Here, the groove. This is called nasal meatus. So you have 3 meata. What is the purpose of these folds? What is the purpose of this increased surface area? When you inhale the air, if it's too cold, it gets warm. If it's too hot, it is cooled down. That temperature, that temperature exchange, heat exchange, happens because nasal conchae have a lot of blood vessels, small capillaries, small arterioles in them. Does that make sense? The more surface you have, the more plexuses of blood vessels, the more network you have there, the more efficient your temperature heat exchange is. Does that make sense? Another important thing, if you inhale really, really dry air, it gets moistened in the nose. Now, when you exhale through the nose, heat and moisture, at least partially, are reclaimed in the nasal cavity. Does that make sense? Okay. Other structures that help to warm the air and make it more humid are sinuses. So frontal sinuses, shown here in blue, you have maxillary sinuses in red, you have sphenoidal sinuses, shown in orange, and so-called ethmoidal air cells, which are essentially sinuses as well. All those structures are basically empty pockets. When you get stuffy nose, the mucosal secretions, they start to accumulate, block the passageways from sinuses into the nose. Okay, it creates decreased pressure in the sinuses because air gets absorbed from the sinuses, but there is no air coming in. Do you understand what I'm saying? So if air in the sinus normally, if it gets blocked, all that air that was there gets absorbed, nothing new comes in, pressure in the sinus drops, and you experience that stuffy nose, headache feeling. Okay, and in case of extremely severe congestion, sometimes if you press on the maxillary sinuses or in the frontal sinuses, you can feel real pain. Okay, does that make sense? Now, nasal cavity. I will publish the study guide on what you need to know for nasal anatomy. I'm telling you, I think the entire exam on anatomy of respiratory and lymphatic system is 20 or 25 questions. Two systems, there's like very little. Okay. So pharynx. We talked about it. I just want to remind you there are 3 parts. We have nasopharynx, which is entirely respiratory. Okay? So the covering is pseudostratified columnar epithelium. Oropharynx, which is now respiratory and digestive, so the coverage is stratified squamous epithelium. And the green laryngopharynx, which is also part of both digestive and respiratory systems and also has stratified squamous epithelial lining. Do that make sense so far? Okay. Important structures that you should be aware about. Tonsils. So you have pharyngeal tonsils around the pharyngotympanic tube and palatine tonsils in the soft palate, lingual tonsils at the bottom of the tongue right here. Okay, so those pairs of tonsils are essentially mucosa-associated lymphoid tissue, and they are exposed to the pathogens. They provide the initial adaptive response to whatever infection you have. Chronic inflammation of tonsils is called tonsillitis. You're going to have trouble swallowing. It's going to be painful. Okay. Chronically inflamed tonsils can be removed. I don't know how it is done now. I had a pleasure of spending a week when I was a kid in a hospital with a severe ear infection, like really, really bad. I still don't know why. Probably because I just got a bunch of antibiotics. That's all treatment was. No surgery, nothing. But we had people who got tonsillectomy. So it was not, back in the days, it was not an outpatient procedure. They were actually kept in the hospital for several days. And the best joke that you could do, because I was like 10 years of age and I was an idiot, you come to the person after tonsillectomy and tell them, say mama. And then you run away because they're going to beat the crap out of you. They can't speak really. It's really painful what they do. What they used to do, they cut around the tonsil, put a loop around it, and pull it out. Okay? And I mean, it's painful. Local anesthesia, it's bleeding. The upside of it, the only food that you can eat is the ice cream. So eat a bunch of ice cream for a couple of days. You can't swallow any real food. Does that make sense? So in regards to this, we've covered throat before. Nothing new really. Except you have to be aware about the existence of tonsils. Okay. Now here we go to the actual part of respiratory system only, which is called larynx. It's a fairly short tube between the laryngopharynx and the trachea. It connects them. Okay? So what it does, it separates the airway and esophagus, basically. Okay? Epiglottis, when we swallow, epiglottis closes a larynx. Does that make sense? It's elastic cartilage, closes larynx so food doesn't get into the respiratory tract. Also, inside of the larynx, you're going to find vocal folds, structures that are necessary to produce, listen carefully, sound, not the speech, sound. Does that make sense? We will talk about the difference. So upper portion of larynx, basically about here, is stratified squamous epithelium because it can't come in contact with food and so on, right? But then when you move lower, it turns back into the pseudostratified ciliated epithelium, which makes perfect sense because you have a mucous membrane there, you need cilia. Now this time to propel cilia up, to propel mucus upwards so it can reach the junction between the esophagus and the larynx and get swallowed and end up in the stomach. Okay? Now, anatomically, cartilages of interest. So that's larynx right here. The Adam's apple is the prominence, so-called laryngeal prominence, of the thyroid cartilage. Okay? Now below it is cricoid cartilage. A huge portion of the larynx is formed not by the cartilage, but by the membrane, so-called thyrohyoid membrane. And finally, there are paired arytenoid, cuneiform, and carniculate cartilages. 3 of them, you can see them here. Cuneiform cartilage, carniculate cartilage, and arytenoid cartilage. They responsible for modulating the sound that is produced by the vocal folds. Does that make sense? Okay? So, thyroid cartilage and cricoid cartilage are structural, more of a structural tube-forming element. Cuneiform, craniculate, and arytenoid cartilages, they manipulate the vocal folds. And that brings us to the vocal folds. Here, white ones. Can you see the white structures? Those are actual true vocal cords or vocal folds. That space between them, space, like space, it's called glottis. I risk it putting you to sleep, but it's going to be better. So that space, empty space, I'm going to strike it through, is glottis. Okay. Now, structures that connect muscles that are necessary to, manipulate vocal cords. The vestibular folds here, or false vocal cords, they do not produce sound. They manipulate, sort of, vocal cords. Does that make sense? Okay. So, how do we produce sound? When we expel the air, air goes through the glottis, vibrates vocal cords, and you get a sound, not a speech. Do you understand? Because if you just open your mouth and you will start to produce sound, there's not going to be any speech. Speech involves mouth structures. That makes sense? So before we move on to pitch and loudness, think about this. If people lose tongue, they can make sounds, but they cannot talk. Okay? If people lose the functionality of the vocal cords, either due to the nervous system disease, a vagus nerve damage, or sometimes due to the sort of I don't want to say the word sloppy, tracheotomy. It can happen. And sometimes, especially if it's emergency and you really have no time to thoroughly think about it, there are situations when tracheotomy leads to the loss of voice, permanent loss of voice. Even after everything heals, the person cannot speak anymore because vocal cords are damaged. In this case, person knows how to say, just cannot produce the sound. Okay? So pitch. Size and tension of vocal cords. Now with this you can appreciate that, generally the female voice is higher than male's voice. Intrinsically because of the anatomical structure of the vocal cord. So if you are concerned that you cannot have the same voice range as, Freddie Mercury or Adam Lambert, don't beat yourself up, it's probably largely genetic. Some of it is definitely exercise, but a lot of it is genetic, Loudness. Now this is how fast and strong you expel the air. Does that make sense? When you speak really, really loud, do you get tired? Usually, yes, because you need to put an additional actual physical effort to expel the air. When you scream or yell really loud, you often do, like people squat, no, seriously, you have to squat to expel the air from your lungs more efficiently at the higher rate. Does that make sense? Okay. Now, not only so without vocal cords, you cannot produce the sound. But sound modulations, other structures that actually change the sound, sinuses and nasal cavity. When you get stuffy nose, your voice changes. Okay? Another interesting thing, I don't know if you've noticed, did you hear your voice on the recordings? Does it sound different? Because you hear basically two sounds. Sound that you produce, you hear it through the ear, and sound from inside of your head. Okay, so it's combination. That's what you hear. When you record the sound that comes out of your mouth, the true sound of your voice, the way other people hear you. And often, people don't like their voice recorded, just because it's weird, just because it doesn't sound familiar. Okay? Now, an interesting thing about vocal cords, they may help you to lift weights in so-called Valsalva's Maneuver. You can imagine that if vocal cords are closed, then air cannot come out from the lungs. Okay, so in Valsalva's Maneuver, when people say lift weights, they, when you lift something really, really heavy, your air in the lungs, it is pressed by, say, a force of the core muscles, and sometimes you just inhale a little bit to stabilize the trunk. Basically, you inflate your thorax to stabilize the trunk. Does that make sense? And if you ever try to lift something heavy and the person, will start to say a joke and you will start to laugh, you're risking to drop the thing that you're trying to lift. Does that make sense? Another reason for Valsalva's Maneuver is to help with defecation. When people constipated, that extra effort trying to push the feces out of the rectum is to squeeze the abdomen, okay, which will increase the pressure inside of the abdominal cavity. And the reason why it can get increased is because the vocal cords are closed, glottis is closed, air doesn't leave the thorax, so you can actually increase pressure inside of the abdominal cavity. If you would try to say something, the air will immediately leave and the pressure will drop and you won't be able to do that. Does that make sense? Can you see that? As we go from larynx, we end up in the trachea. There's a little tiny tube that I highlight here. Okay. So there are 3 layers into the trachea. You have a mucosa with lamina propria and ciliated epithelium, pseudostratified ciliated, so you can see pseudostratified epithelium, columnar epithelium, which with goblet cells that produce mucus. Okay, then you have submucosa, which is connective tissue, quite unremarkable. And then you have adventitia. Okay, so basically connective tissue that surrounds the hyaline cartilage. If you ever, remember the lungs that we inflated? Remember the trachea? Like, it's almost circles of the cartilage. They're not full circles. Okay? They're more like horseshoes, shape-wise. So that's the cartilage. But that's hyaline cartilage, and it's pretty solid. Okay? I've never done tracheotomy in a human, but I did several tracheotomies in mice, and they really solid. So you have like scissors, you have to cut through, and then I tried to resuscitate a couple of mice this way. And yeah, a couple of them actually survived. I was very proud of myself. It was though weird because they had a tube sticking out of the trachea. It was terminal, don't get me wrong. I just needed them for experiment, and they had respiratory distress. So there's the mouse lying on the stage with a tube, and there's the guy trying to inflate a mouse, basically. Pumping the air. Now, the ends of those horseshoe-like incomplete rings are connected by the muscle called trachealis muscle. When it contracts, we cough. Okay? Sorry, but I couldn't resist. Like now, there's some sort of irritation. Okay? It can be dust. It can be accumulation of mucus. Okay? When you're sick, mucus produce, say you have a runny nose. Okay? All that mucus that is produced, not all, but a big portion of it that's produced in your nose will flow down the posterior wall of the pharynx through the larynx into the trachea, and that increased amount of mucus will be forcefully expelled by coughing. That makes sense? At the end here, where trachea splits into two bronchi, there's a structure called carina. Okay. So basically you have a trachea, you have primary bronchi, and that area here is carina. So far, we go through the conducting zone. It's all conducting zone. And then when trachea splits, it splits into primary bronchi. Primary bronchi supply air to the lungs. So right primary bronchus will supply air to the right lung, left primary to the left lung. Surprise, surprise. Then each primary bronchus branches into the secondary or lobar bronchi. So you see the right lung here has 3 lobes, and the left lung has 2 lobes. So you're going to have 3 right lobar bronchi and 2 left lobar bronchi. Does that make sense? And then each lobe of the lung is separated into segments. So tertiary bronchi start to supply segments. So that's segmental bronchus, that's segmental bronchus, that's segmental bronchus. So far, that makes sense. We're clear? The only degree of division that I want you to know: primary, secondary, tertiary. And the name, like main, lobar, segmental. Because bronchi branch, they have 23 orders of branching. So main bronchi, number 1. Lobar, number 2. Segmental, number 3. And you go number 4, 5, 6, up to 23. You can imagine that the smallest bronchi, we call them bronchiole, really, really tiny. Okay. Now, smaller and smaller they get, the less and less cartilage they have. Basically, small bronchioles have only connective tissue. That makes sense. Now, can they change the diameter? Generally speaking, your respiratory passages like bronchioles, can they change the diameter? Come on. When people have asphyxia due to the allergic reaction, bronchioles constrict. Now, big bronchi cannot change the diameter. Like main bronchi, no way. No. Imagine what catastrophe it would be if your trachea would just collapse. You would suffocate in a matter of minutes, right? No, we're talking about small bronchi. Do you understand? That they can do it, and they do it all the time. They regulate the airflow. When all of them suddenly and simultaneously get constricted, then you have that respiratory arrest. Okay? Does that make sense? Now, as bronchi become smaller and smaller and smaller, not only cartilage goes away and connective tissue replaces the cartilage, but also epithelium goes from pseudostratified columnar to cuboidal. And of course, the constriction happens due to the presence of smooth muscles. Okay. Now, this is really, really small bronchus. You can see the bronchial, the how should I say, the ribbons, the layer of the smooth muscle around it. Okay. By the way, which system has a constrictive effect on bronchioles, and which system has a dilating effect? Sympathetic versus parasympathetic. Which one dilates? Sympathetic. Because when you're excited, you need more air coming in. Does that make sense? And when you are relaxed, you don't need that much air. Bronchi constrict. That's parasympathetic. Good? So that really, really small bronchiole here branches off in the terminal bronchiole. So that's the start of the respiratory zone. The tiny little, basically like a trunk, terminal bronchiole branches into the respiratory bronchioles. And respiratory bronchioles branch farther in the alveolar ducts, which branch in the alveoli. Okay? Do they look to you like bunches of grapes? Yeah, me too. Each bunch like this is called alveolar sac. French aficionados, but sac in French means bag. Alveolar bag, basically. Okay. What you saw, remember when we inflated the lung, the white stuff? You saw alveoli, basically, going inflated, deflated. Think about the alveoli. Each alveolus is a small balloon, elastic balloon. Does that make sense? And it will behave largely like a balloon. So far, we're clear about it. We're good. Okay. Alveoli are connected to each other. You can see a bunch of tiny little dots here. Those are alveolar pores. Now, if you would look at each alveolar sac, you will see that outside, on the outside wall, outside of alveoli, there's a lot of capillaries. Okay, pulmonary capillaries. You can see that network here. Okay, basically it's like a network of capillaries without alveoli. So they make up this enormous network which allows really efficient and rapid gas exchange. Now if you think about it, so this is your capillary. I'm going to draw it in red, okay, with endothelial cells, right? Does that make sense? Then you have basement membrane, and then you have the alveolar epithelium. Turns out alveolar epithelium is also simple squamous. Okay, so we've got simple squamous epithelium in the blood vessel, simple squamous epithelium in the alveolus, and on top of that, technically speaking, like all laws of physiology say that epithelium has to have a basement membrane. Okay? Now, in case of these two layers of cells, the basement membrane becomes one. They basically share it. Does that make sense? We say that basement membranes of alveolar epithelium and vascular epithelium, they fused. Am I clear? Like imagine this room shares the wall with the next room. It's the same wall. We don't build two separate walls for two adjacent rooms. We're clear? So, those epithelial cells, simple squamous cells that make up the majority of the alveolar wall, are called type 1 alveolar cells. Along with type 1 alveolar cells, you're going to find cuboidal type 2 alveolar cells. They produce surfactant. So I want to remind you, surfactant is the chemical that reduces the surface tension of water. Does that make sense? We'll get back to this idea and we will talk about the factors that determine the efficiency of the lung, basically. Okay? And pores in alveoli, they connect the adjacent alveoli and equalize the pressure all the time, so that pressure in all parts of the lung are the same. Okay? And finally, there are alveolar macrophages. They crawl around and they try to destroy whatever gets in the lung. There's a lot of things that get in there, despite of all the protective cilium mucus. A tiny little digression I wanted to make. There's a book, anatomy, kids book, on the human anatomy. I can look up the name. I always keep forgetting. When I was a kid, I loved it. It's written by some American doctor, actually. The story is two kids, due to some miracle, they become really, really small and end up in the human body. And they travel through the human body. Okay? And it's a great book. It's very anatomically correct. It's a really good read for kids, because a lot of adventures, and they also, the cat gets in there with them. And one of the adventures is when cat is about to be devoured by alveolar macrophage. They end up in the lung, and the macrophage, like really huge, evil, grouchy cell that is aimed to destroy everything, But and the illustrations are incredible. The only one problem, I think, is that you only can buy it used, because it's kind of hasn't been published. So when macrophages, some of them die, they constantly moved up by the cilia with the mucus, and you swallow them. So you destroy a lot of dead macrophages all the time. So that's basically what alveoli look like. The white ones, I'm going to change the color. These ones, the white ones, these are type 1 cells. Does that make sense? The green ones are type 2 cells, the ones that produce surfactants. Blue ones are macrophages. And I want to highlight here, think about this. Type 1 and type 2 cells, they sit in place. They don't go anywhere. macrophages, quite literally, they crawl very, very slowly, but they crawl like harvesters. Okay? And then you can see pores here. So this red stuff, those are capillaries that run around alveoli. That makes sense. They're really small. And this one shows you the respiratory membrane. So this whole thing is the respiratory membrane. You see the alveolar epithelium, the vascular epithelium, and the tiny layer of basement membrane between them. Do I make sense? Good? Moving on. So, lung. Left lung is smaller. Everybody understands why. You gotta have a heart. Okay. This is the root of the lung, the hilum. We already saw the hilum in the... so that's going to be a hilum right here. Like an indentation, sort of. We saw the hilum in lymph nodes. Sorry, lymph nodes. Basically, the majority of organs that have sort of a bean shape, and they have a certain point where blood vessels and nerves, they all come in, that point will be called a hilum. We have a hilum at lymph nodes, we have a hilum at the kidney, we have a hilum at the lung. We clear? The apex is the upper portion. You have to understand that lung is like a bag that stores alveoli. This bag is made of really elastic connective tissue. Does that make sense? Now, if you look at the left lung, it will have cardiac notch, the little space for the heart. We'll go back to the very, very first slide. It will be more obvious here. No, not more obvious, not really. Well, heart, kind of here. So you see that little notch? That's cardiac notch. Okay? What you need to remember about the lung is that it is the organ with two separate circulations, basically. Right? Think about it for a second. You have pulmonary circulation, which goes to alveoli and nowhere else. Pulmonary circulation has practically no role of oxygen. How to say it better? The function is to get rid of CO2 and bring oxygen back to all the tissues. Does that make sense? And then there are not here, but there are bronchial arteries and bronchial veins, blood vessels that supply blood to the lungs themselves, to the tissue of the lungs. Do you see the difference between like pulmonary and bronchial circulation? Okay. So as I said, right lung, 3 lobes. You have to know there's 3 lobes. And you have to know the fissures that separate them. So superior and medial lobe is separated by the horizontal. Inferior and middle is separated by oblique. In the left lung, only 2 lobes. And they're separated by the oblique fissure. So know the lobes, know the fissures. And then if you start to break it down farther, you will see that each lobe can be separated into the segments. Okay, segments are colored differently in these images. Okay, you can see different colors, right? Those are bronchioles running to specific segments. Am I clear? And then each segment is separated more in the lobules. Okay, that's the last thing that we can actually see. Now, why segments are clinically important? It's basically the last structure that can be independently removed. So if there is an infection, say there's a chronic mycobacterial infection that is antibiotic resistant, you cannot get rid of it, you need to do something about it, you can do a surgery and remove the infected lung segment. Or somebody has got lucky, don't get me wrong, and got diagnosed with very early stage lung cancer. Why I said lucky? Because very early stage. Okay? No metastasis, just a certain area of a lung that is affected. You can remove that segment and the rest of the lung will remain functional. That make sense? Good? So I talked about pulmonary circulation, okay? So that shows you the pulmonary trunk, the pulmonary arteries, and then you can see the veins, pulmonary veins running back from the lungs to the heart. Now, bronchial circulation, as I mentioned, is the blood to the lung tissue. Okay. Now, bronchial veins, they deliver the blood back into the pulmonary veins, so they don't have any special pathway. Does that make sense? So, do they decrease the oxygen content in the blood a little bit? Yes. Is that a lot? No. Because if you think about it, the amount of muscle tissue in the bronchioles is really small. They do not consume a lot of oxygen. They do not produce a lot of CO2. Does that make sense? They do not produce a lot of effort. Connective tissue that lungs are made of, absolutely not metabolically, I mean, it's metabolically active, but it's not incredibly active, like muscles or brain or liver. Does that make sense? So when we say, blood that goes to the lungs, we usually imply pulmonary circulation, not bronchial circulation. That makes sense? Now, imagine that this is the model of a lung. Okay? Now, we're gonna talk about some imaginary things, right? So, the plastic is pleural cavity. On the inside, just imagine that on the inside, that plastic is covered by pleura. Thin serous membrane that produces fluid, pleural fluid. So pleura that covers the cavity, you can see it here actually, so that's that white line. I'm gonna go over it. So that line is the parietal pleura. Parietal always refers to the membrane that covers the cavity. We're clear? And then this is the visceral pleura. Now imagine that these two balloons, on the outside of balloons, there's a same membrane. Essentially, if you would look at this transverse section, the cross section of the lungs, you will see that parietal and visceral pleura, they are the same. Especially, look here. So I'm going to trace the visceral pleura first. So look at, I need to use my toy. Look around here. So I'm tracing visceral pleura. I get to the hilum, I turn around, and I trace parietal. Does that make sense? It continues. And that space, that's a pleural cavity, filled with a fluid. Okay? So fluid decreases the surface tension of the lung tissue itself, so it's easier for lungs to expand and recoil. Good? Breathing. It's all about the gas. I'm going to show you how to breathe. This, the bottom part of that bell, is diaphragm. Opening in the stopper is trachea, bronchi, all that kind of stuff. Okay? Green balloons are the lungs. That makes sense? And the space between the balloons and the bell, the wall, is the pleural cavity. Is that understood? Let's talk about the pressures. Right now, what is the pressure in the now? What is the pressure inside the lungs compared to the pressure in the room? Equal. The same, right? Do you understand? So in order, remember that air always goes from higher pressure to lower pressure. So to inspire, we need to, well, either make atmospheric pressure higher, which would be incredibly hard to do, honestly, or we can make a pressure in the lungs lower. Does that make sense? To expire, to get the gas out of the lungs, we probably going to increase the pressure inside the lungs to push the air out. Am I clear? Because we presume that atmospheric pressure doesn't change. Okay? Now, look at me. I'm going to inspire. At the top of my inspiration, what was the pressure in my lungs? Same as in the room, because there was no exchange. Does that make sense? When there is no gas movement, it means that the pressures are equal. Do you understand? When there is gas movement, gas moves towards lower pressure. Okay? So, for our purposes, we consider that respiratory pressure equals 0 when it's atmospheric pressure. So basically, if I will just stop breathing for a second, my respiratory pressure is 0. That makes sense? Because atmospheric pressure in the lungs is 0. Am I clear? Good. Negative respiratory pressure is lower than atmospheric, positive is higher. Think about this. Sorry. Negative respiratory pressure. Pressure inside of the lung. If it's negative inside of the lung, where does the gas go? Inside of the lung. If it's positive, meaning it's higher than atmospheric, then air goes out of the lungs. Does that make sense? So negative respiratory pressure means inspiration, and positive respiratory pressure means expiration. Am I clear? So that pressure inside of the lung that I refer to is called intrapulmonary. Pressure inside the alveoli. Does it make change? Okay. Now there is a certain pressure in the pleural cavity, which is called intrapleural. It is always, okay. In healthy people, it's negative. If nothing is wrong, it's negative. Okay? It's like now, it's negative. Does that make sense? So lungs expand. It's really important. And you don't really need much to expand the lungs. Does that make sense? If it's lower, then lungs will remain expanded. Does that make sense? Now think about this. If you have an inflammation of pleura, okay, pleuritis of some sort, and fluid starts to accumulate in the pleural cavity. Accumulating fluid here will lead to the lung collapse. Does that make sense? Because pressure here will rise. That pressure will start to work against the lung, and lung will collapse. Okay? So, why this pressure, intrapleural pressure, is negative? First of all, because lungs are elastic and they constantly try to recoil, to become smaller. Okay? Does that make sense? As they, quote unquote, try to become smaller, the volume of pleural cavity tries to become bigger. When volume increases, pressure decreases. Does that make sense? Okay? And of course, you know, the chest wall. Chest wall expands, pleural cavity expands, again, intrapleural pressure becomes negative. So the really like key points, the highlights here, real important physiological highlights, is that first, when there is no air movement, the pressure in the alveoli and outside, the atmospheric pressure, they're the same. That makes sense? If everything's okay with the patient, with the human, then intrapleural pressure will be always lower than intrapulmonary, always, to keep the lungs inflated. Are we clear? So what if there's something wrong and the intrapleural pressure starts to increase? This is called pneumothorax, right? Lung collapse. There's something piercing the chest wall so that air gets the access to the pleural cavity. The pressure inside of the pleural cavity and the pressure inside of the lung, they become equal. No, seriously, I'm not saying that you open somebody's chest and take an air pump and start pumping air in the pleural cavity in order to cause the lung to collapse. The thing is, if this pressure is atmospheric and this pressure is atmospheric, lung will collapse by itself. It's elastic. It will just recoil. That's it. Does that make sense? So basically that negative pressure that is called transpulmonary pressure. Transpulmonary pressure is the difference here. Difference between the lung and the pleural cavity. So transpulmonary pressure here. Transpulmonary pressure should be always more than 0. If it equals 0, the lungs will collapse. And as we discussed, you just suck the air out of the pleural cavity to re-inflate the lung. Does that make sense? stick the needle, suck it out, I suppose. Okay. Now, another condition. Now, this is the situation. Think about this. We talk about pressure in the lung versus pressure in the pleural cavity. One way to cause lung to collapse is to increase the pressure in the pleural cavity. That is called pneumothorax. Another way to cause lung to collapse is to decrease the pressure in the lung without changing the volume of the thorax. Okay? Does that make sense? So if something is plugging bronchioles, air doesn't reach through the bronchioles to the alveoli, the pressure in the alveoli starts to drop. If we talk about massive pressure drop, okay, massive number of alveoli, you have the entire fragment of the lung that will collapse. And technically, you know, suffocate someone, eventually lungs will collapse. This is called atelectasis. Do you see the two different approaches that end up with the same result? Either you block the air access into the lung, or you give air the access into the pleural cavity. That makes sense? So don't suffocate someone, please. Now, several gas laws. We're going to talk about the most loved subject in high school and college, I know, physics. So we're going to talk about a few gas laws, and probably the most important is the Boyle's law. I would say it this way. If you change the volume, you change the pressure. You can say it otherwise. So, look, I'm going to change the volume of pleural cavity, okay, by pulling the diaphragm down. So expand pleural cavity. When I increase the volume, I decrease the pressure. Pressure in the pleural cavity decreases. Pressure in the lungs decreases, they inflate. I decrease the volume, I increase the pressure, I push the air out of the lungs. Does that make sense? That's it. No, seriously. The whole pulmonary ventilation is about changing volumes and changing pressures. So you have to, and you just can't imagine, you know, as the volume becomes bigger, the pressure, meaning chances of those tiny little molecules to hit the walls of the cylinder, the pressure becomes lower. You decrease the volume, you increase the pressure. Does it make sense? Inspiration. This is, like, seriously, super simple. The main inspiratory muscle is diaphragm, yeah. Contraction of diaphragm, increased volume of thoracic cavity. Air gets in. Okay, so volume of the lung increases when the cavity increases, right? That makes sense. You understand? Okay. Volume increases, pressure drops, air flows. At the peak of inhalation or inspiration, the pressure, atmospheric pressure and intrapulmonary pressure, they are the same. Does that make sense? That's it. What if you need to produce a forced inspiration? Intercostals. Okay. You really like do this. Okay, if it's more forced, back muscles, some chest muscles, so pectoralis minor, sternocleidomastoid, just to lift. So think about this. Imagine that in addition to this, to pulling on the diaphragm, I would also be able to stretch the bell itself up. That would be forced inspiration. That make sense? So a little reference to the disease when sometimes a diaphragm gets paralyzed, disease called polio. People who contracted polio and were unlucky enough to get diaphragm paralyzed, they had to sleep in iron lung, which is a machine that breathes for themselves. Does that make sense? You still can breathe. You can forcefully breathe. But when you are asleep, I mean, you cannot sleep and consciously control your forceful inspiration. Does that make sense? Those of you who ever experienced asthma attack know how terrible it is to go to sleep because you don't know if you're going to wake up, you're going to suffocate. Because you really have to force yourself to breathe. Okay? Yes? First, it would be really nice to have one just, for the demonstrations, like a big pump. The first woman that was placed in the iron lung actually died in about like 2010. So she lived up to 63 years of age. I mean, and I don't think she died due to the respiratory illness. She had some other problems. Okay, so it's not like, it extends your living for a mere couple of years and then you die anyway. No, it's, forever. Not forever. For a long time. Okay. But that's pretty cool. I didn't know that. I have nobody at Cleveland State I can... Well, maybe. Maybe we can do like one-day field trip. Expiration. Relax diaphragm. Air gets pushed out. That makes sense? And you don't really need to do anything because lungs are elastic. As long as you relax the diaphragm, lungs will start to recoil and they will push the air out. They will decrease the volume, pressure in the lungs increases, the air gets out. Does that make sense? Now, when you have to forcefully expire, you actually make an effort. Like you even can push your shoulders forward and closer to each other to additionally decrease the thoracic volume. That make sense? One of the reasons with age, respiratory activity is impaired, right? The reason why you can expand your chest, one of the reasons, is that ribs and sternum are connected by cartilage. With age, cartilage becomes ossified, and the elasticity of the ribcage decreases. So your ability to, say, forcefully inspire to expand your chest also decreases. Another reason, if you think about it, if you look at some elderly patients, they often walk like this. That immediately decreases the volume of your thoracic cavity, automatically decreases the volume of your lungs, and makes it harder to inhale because they actually have to work against some additional extra weight put on the thoracic cavity. Does that make sense? Okay. Now this graph here shows you the dynamics of the inspiration and expiration and the pressure in inspiration and expiration. So the upper graph shows you intrapulmonary pressure. It makes perfect sense, really. Okay? So intrapulmonary pressure, pressure in the alveoli, what we call pressure in the lungs. Okay? It becomes lower as we inspire, and then at the peak of inspiration, at the end of inspiration, it is equal to the atmospheric. And then as we expire, pressure in the lungs increases. Does that make sense? Now, pressure in the pulmonary cavity, it progressively decreases to allow for the stretch of the lungs. Does that make sense? So it progressively decreases, lungs get stretched, okay? And then it increases marginally because lungs at expiration point start to recoil. Does that make sense? Okay? And that shows you the volume of breath. It's like really straightforward. Your tidal volume is about 500 milliliters. It's the volume of air that you inhale with each breath. Now, what influences the pulmonary ventilation? Quite obviously, resistance of your airways. We discussed the idea of resistance in cardiovascular system. It's kind of, sort of continuation. The resistance is really marginal, very small, because you're not pushing fluid, you're pushing gas, okay? It is harder in the smaller bronchioles. In the medium-sized, it's the hardest point, okay? Does that make sense? At the terminal bronchioles, resistance to the air movement is almost gone, because at this point, air starts to diffuse through the walls of the bronchioles. Does that make sense here? Okay. Now, this is the point here, non-elastic source of resistance. What does that mean? Think of, can you imagine the straw? Okay. The wider straw is easier to breathe through than the smaller straw. Good? When we say elastic, think of the balloon. When you try to, I forgot the English word, simple. What do you do with the balloon? Inflate. When you try to inflate the balloon, it's kind of easy in the beginning, but then it becomes harder and harder as the air accumulates in the balloon and works against you. Does that make sense? That's the elastic source of resistance. Because as balloon stretches out, the elastic force increases the pressure, and you have to work against those elastic forces of the balloon itself. Does that make sense? Good? So it's really, really, really minimal role. Right? However, it can become problematic, especially if you decrease the diameter. And remember always, the smaller the diameter, the higher the resistance. Okay? So if suddenly all your bronchioles constrict or get plugged by mucus, so obstruction, okay, you start to experience that basically respiratory distress. Does that make sense? I can't get over my asthma attack. I did it once and it was terrible. Okay, I told you I'm going to let you out 5 minutes early. We're done. I will see you